All right, so I will go ahead and introduce our guest speaker tonight at the next in our installment of the BILH OB webinar series. It gives me great pleasure to rope in Dr. Rebecca Zash, who is on faculty here at BIDMC in the Division of Infectious Disease, and really has been a tremendous friend to our division and department for a long time, both on the research side with her work in Botswana and HIV, especially during pregnancy, but really has played a consultative role for us kind of as our go-to infectious disease physician for questions around pregnancy, women's health, and ID. And so it gives me great pleasure to turn the microphone over to her to talk to us a little bit about HIV antiretroviral treatment and pregnancy.
Great, thank you, Blair, and thanks for inviting me to give this talk on pretty much my favorite subject of HIV, antiretrovirals, and pregnancy. And as Blair said, I'm an ID doctor at BI with a lot of my research focused on HIV and pregnancy, but in Botswana. So I thought I'd just start saying that in the United States, the CDC estimates that just under 5,000 people living with HIV gave birth in 2018. And as you can see here, there's a pretty steady decline of the total number of cases of children diagnosed with HIV since 2014, with a total of 65 cases in the United States in 2018. So we're doing better and pretty well there, but we still have some work to do because of issues probably of healthcare access, economic inequality, structural racism, xenophobia. The vast majority of perinatal HIV diagnoses are among Black, African-American children in the United States. So while HIV is relatively uncommon in pregnancy here, that's definitely not true globally. More than 90% of pregnant people with HIV live in the 21 countries that are seen here on the map in sub-Saharan Africa and India. And really because HIV is very specifically targeting young, sexually active women, and also requires the use of a daily medication, the magnitude of antiretroviral treatment exposure in pregnancy due to HIV in countries with high prevalence, like seen in the map, really outweighs that for any other drug in history. And in Botswana, where I work, for example, 1 in 4 of all births in the country is exposed to antiretrovirals in utero. And because Botswana has done a very good job of providing HIV treatment, almost 80% of these are exposed throughout the pregnancy from conception to delivery. So it's really important. Well, it says my battery is running out. Hold on 1 second, I'm really sorry.
We will digest your slide while you find your battery. We want
There we go, I'm plugged in, sorry. That would be a disaster. So I just wanted to remind everyone that without antiretroviral treatment, about 20% or so of non-breastfed infants and up to 40–45% of breastfed infants would acquire HIV. And this bar chart here is basically showing what our antiretroviral interventions over time have done. So we used to do things like give a very short course of a single antiretroviral, a single dose at the time of onset of labor, and then kind of combining them. And each step along the way really got vertical transmission lower and lower. But this last bar here is data from Botswana that in a program where it gave 3-drug antiretroviral treatment standard care, even in 100% breastfeeding population, And in real world data, the rate of HIV transmission to the infant was just about 1%. So that's really exceptionally efficacious. And then HIV transmission to an infant can actually approach 0% in the setting of sustained viral suppression on ART throughout pregnancy without breastfeeding. And this is a large cohort in France, where you can see that there were 0 HIV transmissions to the baby among almost more than 2,500 people who are on their ART started before conception and whose viral loads remained undetectable in pregnancy. And even those who started a little bit later in the first trimester here, as long as their viral load was less than 50, was suppressed the whole pregnancy. Again, extraordinarily low levels of vertical transmission. And I think this is really important because it kind of proves that U equals U also applies to ART in pregnancy and to patients and their infants. And if you're not familiar with U equals U, it's our big thing in the HIV world. It's a massive campaign to let people know that if your HIV viral load is undetectable, then your HIV is untransmittable. And it's really meant to be both a motivation to adhere to antiretroviral medications, but also a way to sort of give people living with HIV hope that they can live their lives without fear of infecting others, that they can really have much more normal lives. And so it's really important that we put this message in for pregnant people as well. So ART treatment is pretty obviously critical for preventing pediatric HIV infections, but it's also really important for improving maternal health, for preventing transmission of HIV to sexual partners. And so to really achieve U equals U for pregnancy, there's kind of 2 steps. The first is to identify all the people living with HIV who are pregnant. And the second is to provide them safe and effective ART. So I'm not going to obviously ask for raising hands here, but I couldn't take out all my clinical scenarios. So here's a little clinical scenario about HIV testing, where all of the following people who initially tested negative for HIV in pregnancy, of all of these people, who should be retested in the 3rd trimester, perhaps because they're at risk of getting HIV during their pregnancy. And this is really getting at, making sure we test everybody to get every last case of HIV in pregnancy. So I'll give you like 10 seconds to think about your answer, and you can be wrong. So according to DHHS recommendations, anyone who's at risk of HIV should be retested in the 3rd trimester. And in this scenario, that includes people whose partners inject drug, people who have an unexplained fever, rash, and leukopenia, which could indicate acute HIV infection, people who report a new sexual partner during their pregnancy, and people who have moved or coming from areas of higher HIV incidence. And here I just put what all of the recommendations are. In addition to that, what I said before, I think it's important to note they recommend anyone with an STI be retested in the 3rd trimester, and anyone delivering at a facility that has more than 1 HIV case per 1,000 pregnancies per year. Basically, just if you are at a place that has a relatively high risk of HIV. I think these are fairly obvious, but sometimes we forget, especially with new sexual partners, new STIs. And again, we're trying to get this down from 0.5% to really no pediatric HIV infections in our country. And then the second step here is to provide safe and effective ART to all people living with HIV who are pregnant, or ideally before they become pregnant. So I wanted to take a brief step back to review some of the basics of antiretroviral treatment. I know that sometimes we kind of have this word salad of antiretroviral drugs, and it's very confusing. There's a generic name, there's a 3-letter abbreviation, there's a brand name, and then totally other names when the drugs are combined. But in reality, ART treatment is kind of straightforward. And generally speaking, antiretroviral treatment is 3 drugs taken together. I put an asterisk there because there's some sort of cutting edge treatment strategies that use just 2 drugs. But these are really things we don't do regularly, even in HIV clinic, and have absolutely no data for pregnancy. So I'm just going to kind of ignore that and go with the basics here. So to come up with this 3-drug regimen, basically you have to take a drug from bin 1, backbone 1, a drug from bin 2, backbone 2, and then a drug from bin 3, which is the 3rd drug. And for backbone 1, there's really only 4 choices. For backbone 2, there's only 2 choices. And for this 3rd class, there's a lot of choices, but really they're just divided into 3 different classes: integrase inhibitors, or INSTIs, protease inhibitors, PIs, and non-nucleoside reverse transcriptase inhibitors, or NNRTIs. And integrase inhibitors include things like Dolutegravir, Bictegravir, Raltegravir, Elvitegravir, Cobicistat. Protease inhibitors include Darunavir, Ritonavir, Atazanavir, Ritonavir, Lopinavir, Ritonavir. And non-nucleoside reverse transcriptase inhibitors, NNRTIs, include things like efavirenz, etravirine, nevirapine, rilpivirine, doravirine. And it sometimes confuses people because all of the protease inhibitors, as well as Elvitegravir, have a 2nd drug attached to them, and that's because they require boosters. And ritonavir and cobicistat are just boosting agents that help get the drugs to the appropriate level. So I just think of these as all one drug, even though it kind of looks like you have 4 drugs sometime in a regimen. And don't let the whole list overwhelm you, because of all of these drugs, there really aren't that many preferred drugs for pregnancy. And so the DHHS preferred ARVs for pregnancy are highlighted here in red. 3 from backbone 1, the 2 from backbone 2, and only 4 from the 3rd drugs, which include Dolutegravir, Raltegravir, Darunavir, Ritonavir, and Atazanavir, Ritonavir. There's actually no NNRTIs that are preferred ART in pregnancy now. So hopefully this kind of shrinks it down for you, because it's really, it's a little overwhelming, but it's not that much. And then where it gets really confusing is that most modern ART combines different antiretrovirals into one pill and gives them new names. This is obviously much better for the patient to just have to take one pill. And here is a list of all the current combinations we have, which are 3 drugs combined into one pill that are only taken once a day. And this is not for you to remember names or anything, but just to see that even of the combinations, they're all backbone 1 plus backbone 2 plus a 3rd drug. And there's really only one of these combinations, which is a preferred regimen for pregnancy, and that's Triamec, which contains abacavir, 3-TC, and Dolutegravir. So 3-drug ART is critical in pregnancy, and I think the first obvious question is, which ART regimen is the most effective at preventing vertical transmission? And this slide shows PK data for the antiretrovirals that we talked about, and whether the level of the given antiretroviral tends to decline in pregnancy, remain basically stable in pregnancy, or even increase in pregnancy. And the main point here is that despite relatively lower levels in pregnancy for most antiretrovirals, virologic efficacy is maintained. And there's only one exception, and that is with the booster cobicistat. So whether it's combined with Elvitegravir, whether it's on its own, or it can be combined with Darunavir. And with that drug, third trimester levels do not get high enough, which are needed for treatment. So that's the one that we tend to avoid for pharmacokinetics. Oops. And so I wanted to talk a little bit about integrase inhibitors, which have become sort of our go-to regimens. And the reason that we're so excited about them is because integrase inhibitors decrease viral load faster than any of the other kinds of ARVs. And there's two large studies that show that this is true in pregnancy. Instis are the most well tolerated with the fewest side effects. And so because having an elevated viral load is really the strongest predictor of vertical HIV transmission, I think we all pretty much assume that using instis would decrease the risk of vertical transmission. And in a meta-analysis that was recently done of 5 clinical trials, which looked at dolutegravir and INSTI compared to efavirenz and an RTI, there certainly was a lot more people who had suppressed viral load at delivery, 90% with DTG and only 72% with efavirenz. But this actually didn't translate into a lower risk of vertical transmission. The risk was very, very low, around 1%, but all the transmissions occurred with dolutegravir. And in real world data from Botswana, and this is just from a program, there wasn't any difference among people who used dolutegravir versus efavirenz in transmission to the baby. And again, it was very, very low. So just in summary about ART and effectiveness for preventing vertical transmission, integrase inhibitors, and in particular dolutegravir, do decrease viral load the fastest and lead to more viral suppression at delivery. But there's really no evidence that any particular ART is more effective in preventing vertical transmission. And whatever ART is well tolerated and can get a pregnant person virally suppressed is the most effective for them and can lead to being undetectable and untransmittable. And the one exception, again, is to avoid ART regimens with cobicistat, which is the booster that lowers drug levels in the 3rd trimester. So if most ART is equally effective, the next question is, what ART regimen in pregnancy is the safest? And I'll start out just by saying that it's been very challenging to study the safety of ART in pregnancy. One reason is because of this thing I said, the ART is really 3 drugs taken in combination. So it's hard to isolate the effect of a single drug. And then drugs can actually interact pharmacologically within a regimen. So a single drug might look safe in one combination and not safe in a different combination. And then the second major reason it's been hard is that the vast majority of exposures to antiretrovirals in pregnancy are in countries where systematic surveillance for the safety of drugs in pregnancy has really been lacking. And just to illustrate the point a little bit further, this is a figure that represents the use of different antiretrovirals in pregnancy in the UK over a 10-year period. And you can see that there's 29 different antiretrovirals, 38 different antiretroviral combinations. And most of the treatment decisions are individualized, leading to a potential for indication bias when comparing these drugs to each other. And so you can see why it's difficult to get good pregnancy safety data in this kind of situation. Which is why, and I'll talk you through some of this data going forward, but a lot of the pregnancy safety data that we have comes from countries where there's a high incidence of HIV, like Botswana, where I work. And what's unique in Botswana is that, number one, we have a very good ability to capture the pregnancy outcomes. There's very good medical records. People actually bring them for delivery. Most people deliver in a healthcare facility. And this is not a good thing, but there's no termination of pregnancy and very little prenatal diagnosis. So we do know what happens to most of the pregnancies. And then the huge advantage is the large number of exposures, where HIV prevalence is 25%. Almost now 95% of people take antiretrovirals in pregnancy, and close to 80% of those are throughout the entire pregnancy. And there are multiple combinations used in Botswana, but only 5 or 6. So it's much easier to do analyses. And not only are there fewer regimens in the UK, but the way it works in Botswana is it's a national program. So Botswana decides this is the ART regimen we're going to use for everybody, and let's do it. And then a few years later, this is the ART regimen we're going to start for everybody. Although people who are already on older regimens stay on. So the regimen that the person is on really depends on the date the ART was started, not individual health factors that might influence birth outcomes. So again, it's just an easier place to study these things. And in this setting, I have been for a long time helping to lead a study called the SAPAMO study, which we started in 2014. And Roger Shapiro is the PI. And our main aims with this study were to evaluate for adverse birth outcomes by different antiretroviral regimens, and also look at birth defects by these regimens. And SAPAMO was the first study to show that the rates of adverse birth outcomes actually do differ by maternal ART regimen. And what this figure is showing you is these are rates of any adverse birth outcome in the light bars and severe birth outcomes in the dark bars. And the first thing is that this group here is people without HIV, and this is a group on 5 different antiretroviral regimens, all started before conception. And we do see that despite having actually well-controlled HIV, high CV4 counts, all the group of people living with HIV had worse birth outcomes compared to those without HIV. And then the second major finding here is that people who are on regimens with efavirenz had much better birth outcomes than those on nevirapine and lopinavir/ritonavir. And we also looked at real specific birth outcomes and found that lopinavir/ritonavir was very specifically associated with an increased risk of preterm birth and very preterm birth, less than 32 weeks. And you can see here, almost 1 in 10 infants born to people who were taking lopinavir from conception were born prior to 32 weeks. And this finding was also then found in 2 randomized control trials and 3 cohort studies from France, Canada, UK, really around the world. And now there's also some evidence from mouse models for an actual mechanism for this effect, which is basically that protease inhibitors decrease plasma progesterone because they decrease prolactin. And when they looked in mice placentas, they found vascular changes with PIs that led to really less efficient placentas. And although this mechanism was mostly found in mice, at the big HIV conference last week, CROI, there was results from a randomized control trial of progesterone for women living with HIV in Zambia. And although overall it didn't have much of an effect, specifically in women who were on protease inhibitors, there was reduced preterm delivery and SGA. So you might be kind of thinking, well, I've just showed you about safety concerns for ARVs that we really don't use anymore, like lopinavir, ritonavir. But I think there's a couple important points. Is that, you know, we've learned all this about lopinavir, ritonavir, and we really don't know, is it specific to that drug, or might it be something that's a class effect and seen in all protease inhibitors? And we don't have that data, even though darunavir, ritonavir, and atazanavir, ritonavir are 2 of our primary recommended regimens in pregnancy now. And then, so the question is obviously, so if preterm is maybe a concern for our protease inhibitors, are there any concerns for our integrase inhibitors? Unfortunately, Botswana, leading the curve again, rolled out Dolutegravir and INSTI in 2016. And so we collected safety data for Dolutegravir, started during pregnancy on this side, and then it took a little bit longer, but also started before conception. And basically, compared to that last bar chart where there are huge differences, Dolutegravir looked very similar to efavirenz, both started during pregnancy and started before conception. And we had just shown you that efavirenz was the safest before in our analyses. And in addition to the Botswana data, there was a recent multi-site randomized controlled trial called VESTED, where they looked at 3 different regimens in pregnant women who were starting ART between 14 and 28 weeks. And basically, for the combination of dolutegravir with TAF compared to the combination of dolutegravir with TDF or efavirenz with TDF, the TAF dolutegravir regimen had fewer adverse birth outcomes, fewer preterm babies, and fewer infants born small for gestational age. So it looks like this specific combination of TAF and dolutegravir, at least for people who start during pregnancy, may have the best outcomes so far. So this was all looking really good for dolutegravir and INSTIs in pregnancy. But in the last few years, there's been a bunch of studies linking integrase inhibitors to excess weight gain, especially when it was combined, dolutegravir was combined with TAF. And one of the most concerning findings was from the ADVANCE study, which was a 3-arm randomized controlled trial of different treatments in non-pregnant adults in South Africa. But what you can see here in the red line is that by 96 weeks of treatment, 14% of women who were randomized to the TAF dolutegravir combination had treatment emergent obesity. So they started at a normal BMI and they became obese. And this was much higher than for TDF with dolutegravir or TDF with efavirenz. And I think it's no surprise to anybody on this call, but you know,
Well, technical difficulty, stand by as hopefully Rebecca rejoins. She is texting me that she's rejoining, so sit tight. We should play a get to know you game or something while we're waiting. Oh, here's you back.
I'm sorry, I don't know what just happened. Oh my goodness. Am I back?
Yes.
Okay, sorry about that. Just got booted off. So I was just saying that this difference in gestational hypertension may be linked to the excess weight gain with dolutegravir. On the other hand, really, we need more data to understand this clinically and how it will play out. Because interestingly, in both the VESTED trial and in SAPAMO, people on dolutegravir did not gain as much weight as people without HIV, and on average gained quite a bit less than what IOM recommends for pregnancy. And we did an analysis to look at early pregnancy weight in SAPAMO, and you see that here. And people with coming into pregnancy with low weight had quite a bit higher risk of severe birth outcomes. And while the opposite is true for maternal hypertension, I think how weight plays in among people living with HIV who are pregnant may be different than potentially than what we see generally. And the jury is really still out. It may be that the dolutegravir weight gain helps people who come in at low weights in pregnancy, but might not do so well for people who come at high weights. And it's really just important to think about the management of people living with HIV as not just controlling the virus, but thinking about all the other usual comorbidities that can lead to adverse pregnancy and maternal outcomes. So just in summary of all of that for ART and pregnancy outcomes, I think, people on ART with well-controlled HIV still might have an elevated risk of adverse birth outcomes, including preterm delivery, SGA, and stillbirth. The risks seem to be highest in older antiretrovirals that we don't recommend anymore. But it may be that preterm is associated with protease inhibitors, and we don't have enough data on the currently recommended protease inhibitors in pregnancy, Dolutegravir and Zanavir. And of all of the integrase inhibitors, we have the most data for dolutegravir, which appears to have really relatively lower risk of adverse birth outcomes, certainly compared to any older ART. But there is these now emerging concerns about the risks of excess weight gain, particularly when it's combined with TAF, and how this could impact future pregnancy outcomes. On the other hand, there's now a randomized controlled trial showing really the best birth outcome with this TAF DTG. So this is an unfolding story, which we just don't have full data about yet. So now on to just a few more clinical scenarios that touch on some other aspects of HIV management in pregnancy. So here's a situation where a woman living with HIV presents for care at 8 weeks with well-controlled HIV on Triomec, which is abacavir, 3-TC, and dolutegravir. And she should, here are your choices, be switched to a darunavir regimen, be switched to a rilpivirine regimen, be switched to a raltegravir regimen, or be counseled that dolutegravir increases the risk of neural tube defects by 10-fold, but it's too late in pregnancy to prevent neural tube defects, or none of the above. So you can have your few seconds to decide what you think. And I think that the correct answer is none of the above. But I wanted to bring this up because I assume that a lot of people have heard about this link between dolutegravir and neural tube defects. And I want to walk you through the data and the most recent treatment recommendations. So in May 2018, the SAPAMO study first reported on this possible safety signal with dolutegravir and neural tube defects. Basically, we were asked by the WHO to provide them some preliminary data on women and people who'd been on dolutegravir at conception for an upcoming guidelines meeting. And we found a surprisingly high prevalence of neural tube defects, 4 of 426 who had been exposed to dolutegravir at conception. So a prevalence of 0.94%. And it was much higher than all our other comparator groups, which were all around the expected neural tube defect prevalence of 0.1% or 1 per 1,000. And this led to WHO and FDA and EMA all putting out warnings about this potential link between taking dolutegravir-based ART and neural tube defects. And then 1 year later, in 2019, we updated the data with a year more of collection, and we had one more neural tube defect among about 1,200 additional exposures to dolutegravir conception. So the total prevalence was down to 0.3% compared to 0.94%. This was still statistically higher than all the other exposure groups, but the absolute difference of 0.2 to 0.27% was really quite small. And then our latest update occurred last year, last April, where we showed that from 0.3, the prevalence of neural tube defects with dolutegravir conception came down to 0.19%. And it did seem to be kind of leveling off right around 0.19%. Oops. And so what was also, I think, important during this time is that our study in SAPAMO agreed with 3 of the other 4 large studies of this, including a Brazil retrospective cohort, the Antiretroviral Pregnancy Registry in the United States, another Botswana study that was done at non-SAPAMO sites. They all had a prevalence, fairly around 0.2%, while there was really nothing from Europe, where they had none in 280 exposures. So, I think that with the neural tube defect prevalence in the general population of about 0.1%, this small increased potential risk with dolutegravir can't be completely ruled out, but it's really small enough that we no longer think that it's clinically significant for our patients with HIV. And because of this reassuring data, and because of this small absolute difference, in December last year, the DHHS guidelines were updated, and now dolutegravir is considered as a preferred regimen for all the categories: people who are starting ART in pregnancy, people who need to restart, people who need to switch, and also for non-pregnant people who want to become or are trying to conceive. Okay, so here's a slightly different scenario where a woman living with HIV presents for care again in around 8 weeks with well-controlled HIV on Triumeq again, which is with abacavir and dolutegravir. She had heard about the birth defects with dolutegravir and wants to switch her regimen. So would you switch off a regimen to darunavir, switch her off a regimen to rilpivirine, switch her off a regimen to raltegravir, or before making a decision, maybe do some counseling that the risks of switching off dolutegravir may outweigh any benefit at this point in pregnancy, or none of the above? I'll give you a few seconds here. And, I think this one's a little bit more clear, but before this decision should be made, it's really important, I think, that this patient be counseled about the risks of switching off of dolutegravir. And besides the fact that the risk period for neural tube defects may have already passed in her pregnancy, there's a couple other important points to emphasize in this in this kind of counseling. One really important thing is that there isn't this kind of similar data for the other preferred antiretroviral regimens in pregnancy. So for raltegravir, atazanavir, and darunavir, we just don't have this kind of SAPAMO-like data. So we don't know, could that also increase neural tube defect risk? Would we want to switch somebody from a drug with a known small effect to one without information? And then another important point is that switching antiretroviral treatment during pregnancy has been associated with treatment failure. There was a cohort from France that looked at virally suppressed women at the beginning of pregnancy who switched ARTs because of pregnancy, and 20% who switched became viremic compared to 0% who stayed on their regimen. And so the DHHS is quite strong in their recommendation that women who are already on a suppressive regimen when pregnancy occurs should continue their regimen. And again, the one exception to this is regimens containing cobicistat, because we're worried that they won't get good enough levels in the third trimester. So just in summary, in terms of ART and birth defects, the initial signal that we saw for dolutegravir and neural tube defects has decreased over time and now is approximately 0.2% for dolutegravir and 0.1% in other ART and in the general population. There's no similar data for rare defects for any of the other recommended regimens in pregnancy. And because of all of this, in 2020, DHHS updated their guidelines to include dolutegravir as a preferred regimen for everybody in pregnancy, as well as those planning to conceive. And switching someone from an effective ART during pregnancy, which is being tolerated and the viral load is suppressed, is not recommended because of risk of viral rebound when switching, again, except for cobicistat and old drugs. All right, so here's a short clinical scenario on intrapartum care. This patient started ART at 30 weeks and has an HIV viral load of 1,500 copies at 36 weeks, which is about what you would expect for someone who had recently started. They report adherence, viral load is declining nicely, the CD4 count is increasing. So the following management plan, which of the following management plans is recommended? 1, plan for a C-section at 38 weeks with intrapartum IV AZT or zidovudine. 2, plan for intrapartum IV AZT but no C-section. Or 3, repeat the viral load at 39 weeks to make a decision on C-section and IV AZT. Right. So according to the DHHS guidelines, for someone with a viral load of 1,500 at 36 weeks, you should plan for a C-section at 38 weeks with intrapartum IV AZT to reduce the risk of HIV transmission to the infant. And basically, just as a review of their recommendations, an HIV viral load should be taken on everyone at 34 to 36 weeks or 4 to 6 weeks before delivery. And if the viral load is above 1,000 copies, which is not good and which is associated with transmission to the infant, you want to give IV zidovudine at the onset of labor or 3 hours prior to C-section and schedule a C-section for 38 weeks. If the viral load is 50 to 1,000 copies, with less than 50 being completely undetectable, but 50 to 1,000 being kind of this low range, there's not very good recommendations about what to do with IV zidovudine. It says you can consider it. And I think, you can think about, is this somebody who's just started on ART and they're adherent, or is this somebody with adherence issues, and kind of make a risk benefit equation around that. But you don't need to do a C-section. And then there's some recommendations around avoiding fetal scalp electrodes and artificial rupture of membranes and forceps if possible. And then if the viral load is less than 50 between 34 and 36 weeks, and the patient is as adherent and there's no issues, there's no need for IV zidovudine or a scheduled C-section. And then the last clinical scenario I wanted to do was around postpartum care and breastfeeding. So you have this patient, again, on abacavir 3-TC dolutegravir with high CD4 counts, who's been virally suppressed since before conception with an uncomplicated pregnancy. And they ask about breastfeeding. And she notes that she breastfed her older child successfully while living in Nigeria prior to immigrating to the US. So for this patient, would you recommend against breastfeeding or recommend breastfeeding? And so DHHS still recommends against breastfeeding. And I wanted to touch on this issue because I think it's coming up more and more, and people are starting to ask, why doesn't U equal U, why doesn't being suppressed on ART apply to breastfeeding? Why couldn't you, safely breastfeed an infant who's with exposure? And when what you're seeing here is a graph of all the pediatric HIV infections, mostly from low and middle income countries in 2019. And about half up here occurred during pregnancy, and about half down here occurred during breastfeeding. But the reasons, which are in the colored blocks for why these occurred, is number one, that the person did not receive any antiretrovirals during pregnancy or breastfeeding. So these are not breastfeeding failures, but people never got on ART. The second most important reason was that they didn't know they had HIV infection. They had incident HIV infection after their first test during pregnancy or breastfeeding. And that happened, in quite a few here. And then the third most important one was those who stopped taking their antiretrovirals here during pregnancy and during breastfeeding. But there's really no contribution in this from people taking ART successfully and breastfeeding. And so with newer antiretroviral treatment, the risk from HIV transmission, the risk of transmitting HIV to the baby while the person is virally suppressed is mostly just theoretical. On the other hand, we do know that it's very hard to adhere to antiretrovirals with a newborn and in the postpartum period. So this is still of concern. But breastfeeding is recommended by the WHO for people living with HIV in low and middle income countries due to a higher risk of infant mortality, with formula feeding outweighing any kind of risk of HIV transmission during breastfeeding if the person is adherent to medications. And we have to think that some people in our settings may have a similar risk-benefit calculation with some increased risk of infant mortality or infant morbidity when using formula due to poverty and living conditions. And I think it's also really important that people living with HIV in the United States are increasingly choosing to breastfeed anyway. There was a nice study that asked clinicians about this, and HIV clinicians who saw a good number of pregnant patients reported that a third of their HIV patients chose to breastfeed despite being advised not to. So while this is still quite an evolving area, the DHHS did in this last year put out guidelines for counseling and managing women with HIV in the United States who desire breastfeeding. And I expect that this will continue to evolve as we get better breastfeeding data with our more modern antiretroviral treatment. So just to close, if you can remember anything from this kind of long talk, it's that DHHS preferred regimens for the third drug are simple: Dolutegravir, Raltegravir, Darunavir, Ritonavir, and Atazanavir, Ritonavir. And people who are on suppressive antiretroviral treatment should not be switched to a new regimen just because of pregnancy, except in that case where it contains cobicistat, because that decreases the third trimester levels. Adverse pregnancy outcomes are probably more common among women living with HIV and maybe worse with certain antiretroviral treatment regimens, but this data is really still evolving. The HIV viral load at 34 to 36 weeks drives our decisions about intrapartum care. Above 1,000 is bad, below 50 is great, and 50 to 1,000 is really an area where we lack data. And then finally, breastfeeding is still not recommended, but increasingly a reasonable option for people living with HIV, and guidelines to support this choice are now available in DHHS guidelines. So thank you for listening to all that. I'm more than happy to take any questions. And I wanted to just mention at the end that I love working with MFM and the OBs, and I'm currently piloting an ID-OB clinical partnership. So I'm available for ID consultation for OB patients, and I can see them in telehealth or in MFM clinic, and follow pregnant people living with HIV throughout their delivery. There's just a few ID providers who will follow their own, but most of them would like me to follow them. And you can reach me on the pager system or via email with questions or requests at any time. So thank you.
Thank you, Rebecca. We do have a question in the chat from Dr. Collier. Are there registries or other studies being done to evaluate mother-to-infant transmission during lactation in people with undetectable viral load? Getting at your breastfeeding question.
Yeah, again, most of the data is coming from low and middle income countries because most of those people are breastfeeding. So we're getting quite a bit of Dolutegravir data. There's not going to be as much for Atazanavir and Darunavir, and I don't know of any particular studies of those in the United States.
Excellent. Any other questions? That people can unmute themselves as well. I think we all have that capability to ask questions. If not, just a plug for reaching out to schedule any consults with Dr. Zash. We can help coordinate that at MFM. So just like you would do a consult through us, we can help coordinate things for Dr. Zash because we want this partnership to continue. We need our sidekick. And certainly you've been a tremendous help for us in the past year as we've struggled with how to interpret data for COVID and our patients. Thank you for that. And this wonderful talk. Any other questions before we call it a night? I think we're looking good. All right, well, thank you. And this will be up on our website after a while, so the people who missed it tonight can look at it later. All right, take care, everyone.
All right, thank you.